Diseases of Ear, Nose and Throat by P.L. Dhingra. Chapter 7 Disorders of Vestibular System. Disorders of vestibular system cause vertigo and are divided into peripheral, which involve vestibular end organs and their first order neurons, that is, the vestibular nerve. The cause lies in the internal ear or the eighth nerve. They are responsible for 85% of all cases of vertigo. 2. Central, which involve central nervous system after the entrance of vestibular nerve in the brainstem and involve vestibular-ocular, vestibulospinal and other central nervous system pathways. Peripheral vestibular disorders, peripheral lesions of end organs, vestibular nerve, central lesions of brain stem and central connections. Peripheral Meniere's disease, benign paroxysmal positional vertigo, vestibular neuronitis, labyrinthitis, vestibulotoxic drugs, head trauma, perilymph fistula, syphilis, acoustic neuroma. Central lesions of brainstem and central connections, vestibulobasilar insufficiency, posterior inferior cerebellar artery syndrome, basilar migraine, cerebellar disease, multiple sclerosis, tumors of brainstem and fourth ventricle, epilepsy, central cervical vertigo. Peripheral vestibular disorders. 1. Meniere's disease, endolymphatic hydrops. It is characterized by vertigo, fluctuating hearing loss, tinnitus, and a sense of pressure in the involved ear. Vertigo is of sudden onset, lasts for a few minutes to 24 hours or so. 2. Benign paroxysmal positional vertigo, BPPV. It is characterized by vertigo when the head is placed in a certain critical position, such as picking an object from the overhead shelf. There is no hearing loss or other neurologic symptoms. Positional testing establishes the diagnosis and helps to differentiate it from the positional vertigo of central origin. Diseases is caused by a disorder of posterior semicircular canal, though many patients have history of head trauma and ear infections. It has been demonstrated that autoconic debris containing consisting of crystals of calcium carbonate is released from the degenerating macula of the utricle and floats freely in the endolymph. When it settles in the cupula of posterior semicircular canal in a critical head position, it causes displacement of the cupula and vertigo. The vertigo is fatigable on assuming the position repeatedly due to dispersal of the autoconia but can be induced again after a period of rest. Thus, typical history and Dix-Hallpike manure establish the diagnosis. The condition can be treated by performing Epley's maneuver. The principle of this maneuver is to reposition the autocorneal debris from the posterior semicircular canal back into the utricle. The doctor stands behind the patient and assists the stance on the side. The patient is made to sit on the table so that when he is made to lie down, his head is beyond the edge of the table as is done in Dix-Hallpike's maneuver. His face is turned 45 degrees to the affected side. The maneuver consists of 5 positions. Position 1. With the head turned 45 degree, the patient is made to lie down in the head hanging position, Dix-Hallpike's maneuver. It will cause vertigo and nystagmus. Wait till vertigo and nystagmus subside. Position 2. Head is now turned so that the affected ear is facing up at 90-degree rotation. Position 3. The whole body and head are now rotated away from the affected side ear to the lateral recumbent position in 90-degree rotation face down position. Position 4. Patient is now brought to a sitting position while head is still turned to the unaffected side by 45 degree. Position 5. The head is now turned forward and the chin is brought down at 20 degree. There should be a pause at each position till there is no nystagmus or there is slowing of nystagmus before changing to the next position. After maneuver is complete, the patient should maintain an upright position for 48 hours. 80% of the patients will be cured by a single maneuver. If the patient remains symptomatic, the maneuver can be repeated. A bone vibrator placed on the mastoid bone helps to loosen the debris. 3. Vestibular neuronitis. It is characterized by severe vertigo of sudden onset with no cochlear symptoms. Attacks may last from a few days to 2 to 3 weeks. It is thought to occur due to a virus that attacks vestibular ganglion. Management of acute attack is similar to that in Meniere's disease. The disease is usually self limiting. 4. Labyrinthitis. It has been discussed in detail on page 96. Circumscribed labyrinthitis is seen in cases of unsafe type of chronic suppurative otitis media CSOM and fistula test is positive. Serous labyrinthitis is caused by trauma or infection, viral or bacterial, adjacent to the inner ear but without actual invasion. There is severe vertigo and sensorineural hearing loss. A partial or full recovery of inner ear functions is possible if treated early. Purulent labyrinthitis is a complication of CSOM. There is actual bacterial invasion of the inner ear with the total loss of cochlear and vestibular functions. Vertigo is in this condition is due to an acute vestibular failure. There is severe nausea and vomiting. Nystagmus is seen towards opposite side due to destruction of the affected labyrinth. Vestibular toxic drugs. Several drugs causes ototoxicity by damaging the hair cells of the inner ear. Some primarily affect the cochlea while others affect the vestibular labyrinth. Aminoglycoside antibiotics, particularly streptomycin, gentamicin, and kanamycin, have been shown to affect the hair cells of the crista ampullaris and to some extent those of the maculae. Certain other drugs which cause dizziness or unsteadiness are antihypertensives, labyrinthine sedatives, estrogen preparations, diuretics, antimicrobials like naldixic acid, metronidazole, and antimalarials. However, their mode of action may be different. Head trauma. Head injury may cause concussion of labyrinth, completely disrupt the bony labyrinth or even eighth nerve, or cause a perilymph fistula. Severe acoustic trauma, such as the one caused by explosion, can also disturb the vestibular end organs and result in vertigo. A police maneuver for BPPV of posterior canal showing position of patient and corresponding position of otolith. Debris in the posterior canal. A. Patient sitting facing forward. B. Patient lying down in dixhalpic position with head hanging and turned 45 degrees to right, the affected ear. C. Head turned to the left dixhalpic position with the affected ear up. D. Head and body turned as a unit to the unaffected side so that the face is turned to the ground. E. Patient is made to sit with head bent forward by 20 degrees. Perilymph fistula. In this condition, perilymph leaks into the middle ear through the oval window or round window. It can follow as a complication of stapedectomy or ear surgery when stapes is accidentally dislocated. It can also result from sudden pressure changes in the middle ear. Example, barotrauma, diving, forceful valsalva, or raised intracranial pressure, weightlifting, or vigorous coughing. A perilymph fistula causes intermittent vertigo and fluctuating sensorineural hearing loss, sometimes with tinnitus and a sense of fullness in the ear. 8. Syphilis. Syphilis of inner ear, both acquired and congenital, causes dizziness in addition to sensorineural hearing loss. Late congenital syphilis, usually manifesting between 8 and 20 years, mimics Meniere's disease with episodes of acute vertigo, sensorineural hearing loss, and tinnitus. Henbert's sign, that is, a positive fistula test in the presence of an intact tympanic membrane, is present in congenital syphilis. Neurosyphilis, tertiary acquired, can cause central type of vestibular dysfunction. 9. Acoustic neuroma. It has been classified in peripheral vestibular disorders as it arises from the cranial nerve 8 within internal acoustic meatus. It causes only unsteadiness or vague sensation of motion. Severe episodic vertigo, as seen in the end organ disease, is usually missing. Other tumors of temporal bone, that is glomus tumor, carcinoma of external or middle ear, and secondaries, destroy the labyrinth directly and cause vertigo. Central vestibular disorders 1. Vestibulobasilar insufficiency. Vertebrobasilar insufficiency. It is a common cause of central vertigo in patients older than 50 years. There is a transient decrease in cerebral blood flow. The common cause is atherosclerosis. Ischemia in these patients may also be precipitated by hypotension and neck movements when cervical osteophytes press on the vertebral arteries during rotation and extension of head. Vertigo is abrupt in onset, lasts several minutes, and is associated with nausea and vomiting. Other neurological symptoms like visual disturbances, drop attacks, diplopia, hemianopia, dysphagia, and hemiparesis result from ischemia to other areas of the brain. May also accompany vertigo. Some patients only complain of intermittent attacks of dizziness or vertigo on lateral rotation and extension of head. Posterior cerebellar artery syndrome. Wallenberg syndrome. Thrombosis of the posterior inferior cerebellar artery cuts off blood supply to the lateral medullary area. There is violent vertigo along with diplopia, dysphagia, hoarseness, Horner syndrome, sensory loss on ipsilateral side of the face, contralateral side of the body, and ataxia. There may be horizontal or rotational nystagmus to the side of the lesion. 3. Basilar migraine. Migraine is a vascular syndrome producing recurrent headaches with symptom free intervals. Headache is usually unilateral and of throbbing type. Basilar artery migraine produces occipital headaches, visual disturbances, diplopia, and severe vertigo, which is abrupt and may last for 5 to 60 minutes. Basilar migraine is common in adolescent girls with strong menstrual relationship and positive family history. 4. Cerebellar disease. Cerebellum may be affected by hemorrhage, hypertension, infarction, occlusion of the arterial supply, infection, autogenic cerebellar abscess, or tumors, glioma, teratoma, or hemangioma. Acute cerebellar disease may cause severe vertigo, vomiting, and ataxia, stimulating an acute peripheral labyrinthine disorder. Tumors are slow growing and produce classical features of cerebellar disease, that is, incoordination, pass pointing, adiadochokinesia, rebound phenomenon, and wide based gait. Lateral medullary syndrome, inferior cerebellar peduncle, vertigo, nausea, vomiting, and nystagmus, spinocerebellar tracts, ataxia, nucleus ambiguous, cranial nerve 10, 9, 11, 9, hoarseness and dysphagia, decrease descending sympathetic tract, Horner syndrome, uncrossed fibers of spinothalamic tract, loss of pain and temperature on ipsilateral face, decrease descending nucleus and tract of cranial nerve 5, pain and numbness over ipsilateral face, crossed fibers of spinothalamic tract, contralateral loss of pain and temperature of arm, trunk and leg, lateral medullary syndrome, cranial nerve, nucleus of cranial nerve 12, medial longitudinal bundle, inferior cerebellar peduncle, medial lemniscus, pyramid, spinothalamic tract, ventral and dorsal spinocerebellar tracts, descending sympathetic tract, descending nucleus and tracts of cranial nerve 5, nucleus ambiguous, tractus solitarius, vestibular nucleus. Multiple sclerosis. It is a demyelinating disease affecting young adults. Vertigo and dizziness are common complaints. There are other multiple neurological signs and symptoms. Example: blurring or loss of vision, diplopia, dysarthria, paresthesia, and ataxia. Spontaneous nystagmus may be seen. Acquired pendular, pendular nystagmus, dissociated nystagmus, and vertical upbeating nystagmus are important features in diagnosis. 6. Tumors of brainstem and floor of fourth ventricle. Gliomas and astrocytomas may arise from pons and midbrain. Medulloblastoma, ependinomomas, epidermoid cysts, and or teratomas may arise from floor of fourth ventricle. These tumors cause other neurological signs and symptoms in addition to vertigo and dizziness. Positional vertigo and nystagmus may also be presenting feature. CT and MRI resonance imaging are useful in their diagnosis. Epilepsy. Vertigo may occur as an aura in temporal lobe epilepsy. The history of seizure and or unconsciousness following the aura may help in the diagnosis. Sometimes vertigo is the only symptom of epilepsy, which may pose a difficult diagnostic problem. Electroencephalography may show abnormalities during the attack. 8. Cervical vertigo. Vertigo may follow injuries of neck 7 to 10 days after the accident. It is usually provoked with movements of the neck to the side of the injury. Examination shows tenderness of neck, spasm of cervical muscles, and limitation of neck movements. X-ray shows loss of cervical lordosis. Exact mechanism of cervical vertigo is not known. It may be due to disturbed vertebrobasilar circulation, involvement of sympathetic vertebral plexus, or alteration of tonic nuclear flexus. Other causes of vertigo. Ocular vertigo. Normally, balance of the body is maintained by integrated information received from the eyes, labyrinth, and somatosensory system. A mismatch of information from any of these organs causes vertigo, and in this case, from the eyes. Ocular vertigo may occur in case of acute extraocular muscle paralysis or high errors of refraction. 2. Psychogenic vertigo. This diagnosis is suspected in patients suffering from emotional tension and anxiety. Often other symptoms of neurosis, example palpitation, breathlessness, fatigue, insomnia, profuse sweating, and tremors are also present. Symptoms of vertigo is often vague in the form of floating or swimming sensation of or lightheadedness. There is no nystagmus or hearing loss. Caloric tests will show an exaggerated response. Thank you.